respected sir, madam, and all gurus at Mediscan. Very good morning to all of you. Uh, First of all, let me congratulate for completing 43 years of sheer dedication, devotion, and motivating many students like me and shaping our career. So, as you guessed it right, sir, that I've got to know this terminology, vocabulary from one of the article of Shashi Tharoor. I happened to go through one article which he wrote on Mahabharata characters, and he mentioned that there are shades of a character in each personalities, may it be Karna, may it be Krishna, and there were good and evils. So it is the word is derived from the Greek roots, that is agathos is for good and the kakos for bad, and with the logical suffix indicating the combination of these elements. So while preparing this presentation, I found the title very apt for the topic, and hence went through this the title. So I'll take you through three cases which really baffled us over a period of time, and how the outcome happened with the period of time. And later we'll talk about what the possible etiologies and how in clinical practice we can improvise the things. So let us take the first case. So it was the primi gravida, 28 years, non-consanguineous couple, RH positive, and happened to come for first trimester ultrasound screening, which was showing little higher. NT was little on 95th centiles for that period of gestation, but no other ultrasonographic aneuploidy markers were noted, like nasal bone, ductus venosus, and tricuspid interrogation was completely normal. She had high resistance of flow in both the uterine arteries. So based upon these findings, the counseling was done and patient opted for first trimester combined screening. To our notice, we got to know that there are high beta HCG and low PAPE coexisting and consisting with the findings, and there was a risk which was 1 in 22, which is putting her at high risk of T21. Post-test counseling was done. We even counseled them. We can wait for amniocentesis till 17 weeks, but she was very much anxious. The couple was very much anxious, and they wanted to do the test right way at that point of time. So at 13 weeks, we posted her for chorionic villous sampling. So chorionic villous sampling was done at 13 weeks, which revealed the normal component for 13, 18, 21, and sex chromosomes, which came just within, say, 5 days. So on first call, we assured the patient that yes, although the report was abnormal, the combined first trimester screening was showing positive risk, but the initial screening has come normal. Now let us wait for the other report. The chromosomal microarray was also advised, and that report, to our surprise, came out to be trisomy 16 with significant gain of 90,000 kb on 1137 genes on chromosome 16, and it was classified as pathogenic. Now, conflicting with the genetic diagnosis and ultrasound showing structurally otherwise normal fetus, we suspected there can be different cell lines existing in this. So better we retest. We took the help of a genetic consultant, and they also advised that better we wait and do amniocentesis and confirm the findings. Couple agreed with difficulty, but they agreed and they got amniocentesis done. Now, just as the routine protocol, before doing any invasive testing, we have to do the screening, ultrasound-based screening. All the parameters now at 17 weeks were coming at less than 5 centiles. So early onset fetal growth restriction has already started. We did amniocentesis, and amniocentesis showed normal fish for trisomy 16, and eventually the KT also came out to be completely normal. So trisomy 16 was ruled out. On follow-up, we again called at 21 weeks, which again was showing the similar pattern of growth restriction, which was early onset. There was a development of placentomegaly, oligoamnios, and on ultrasound, we found persistent left SVC draining into dilated coronary sinus. There was isolated finding. On Doppler, there was high resistance of flow in uterine arteries, which was persistent right from the first trimester. Again, we could notice even at 20 weeks, the high resistance of flow in umbilical artery also, but MC and ductus venosus Dopplers were normal. So we asked them to follow up 2 weekly, and to this, patient did not come for follow-up till 27 weeks. This was a talk at around 21 weeks, and now 27 weeks she's presenting again with all the features of early growth restriction, along with the umbilical cord cyst. There is a development of placentomegaly, oligomnios, and the left SVC was persistent. The umbilical artery Doppler showed absent and diastolic flow in free loops, and reversal already started at fetal end. MC and DV were becoming normal, but it was the CPR was less than 1. So based upon this criteria, it was already stage 3 FGR, and we did the follow-up plan considering the maternal and fetal workup. But at 28 weeks, the reversal of flow in umbilical artery in all loops started, and stage 3 FGR was already there. Now, ductus venosus showed increased pulsatility after 5 days. Now we again sat back with them and counsel that there is a poor prognosis considering very extremely low birth weight at this point of time, baby weight at this point of time. A couple was very fuming because earlier we said combined first trimester screening, which was positive. Then we said that the another report which is abnormal, but you don't consider it as abnormal because it may be confined to the placenta itself. Then we proved that the fetal aneuploidy is not there. And then again, we are giving them bad news that the fetus is not progressing well. So the scenario was dwindling between good and bad. So at 29 weeks, ultimately, they opted out for aggressive management and the vaginal delivery was planned. 450-gram fresh stillborn fetus was delivered. Placental HP was advised, but needless to say that patient were completely in denial of doing any further investigations. Similarly, another couple came to us. The mother was primey, and she already landed after doing NIPT test with their primary consultant. They had combined first trimester screening, which was again screened positive for T21. And the striking feature in the combined FTS was low PAPE, it was 0.17 multiples of median. Now, couple already did NIPT, and it was showing low risk for 13, 18, 21 XY, which we routinely ask for. But it was an additionally showing the trisomy 16 risk high in the report. Now, screen positive for trisomy 16 again, like in the first case. So in the presence of normal structural normal fetus, possibility of false positive results or different placental cell lines have been explained. We did rescan and we asked them to have amniocentesis, to which they agreed to. When we saw at 14 weeks, there was mild placentomegaly which was developing. These were the findings, and there was high resistance of flow in both the uterine arteries, which we could notice at that point of time. So amniocentesis was planned, and reports were within normal limits. The chromosomal microarray came out to be negative for any aneuploidy or any deletion or duplication. And we posted for 21 weeks scan for anomaly scan. Now, 21 weeks scan showed normal fetal growth like an Doppler study. Now, for routine ANC, she used to visit her gynecologist, and the obstetrician realized at 24 weeks that the growth is not corresponding to the period of gestation. So again, we scanned and we found out that the placentomegaly is increasing. There is a component of growth lag and oligomnios which was increasing in nature. And now the umbilical artery started showing high resistance of flow at 24, right from 24 weeks. So we advised a weekly Doppler study, and it remained as in stage 1. Now, suddenly we got a call at 26 weeks from the obstetrician that the lady presented with abruptio placenta, severe preeclampsia, and even altered DIC profile. They had to do bedside USG, which revealed a significant amount of retroplacental clot. Couple opted for aggressive management because of 26 weeks, and it was very precious baby to them, and NICU counseling was done. Elective emergency hysterotomy was done, which gave birth weight of around 550 gram. Baby was admitted in an ICU, but developed intraventricular hemorrhage on day 3 and unfortunately succumbed on day 3 with neonatal death. Third case and last case, which I'm going to discuss. So this is ongoing pregnancy actually right now. She's a 34 years mother with a previous healthy baby, one history of miscarriage. In first trimester scan, again, there was no ultrasound markers for aneuploidy, but in combined first trimester screening, there was a positive risk for trisomy 21. As we can see in the biochemistry, beta HCG is around 4.3 mom and Pepe is 0.4 mom. Probably this might have contributed to the increased risk of trisomy 21. Then she opted for NIPT, and NIPT again came out to be positive for chromosome 14. So what we asked for, that 21 was completely normal, but again then additional point of chromosome 14 has come to us, and now patient also in dilemma. So we advise them that we need to confirm whether it is a fetal trisomy or NIPT showing false positive test, positive results. So we had to do amniocentesis. Now, when she was posted for amniocentesis, already the high resistance of flow in uterine arteries were there, and mild component of placentomegaly was observed with early onset fetal growth restriction already supervened. Fortunately, the amniocentesis revealed normal chromosomal microarray, and right now she is at 27 weeks with ongoing pregnancy. There is a component of fetal growth restriction, but fortunately the Dopplers are fine. So looking at all these three cases, we had more or less common clinical pattern in all three cases of early onset FGR, conflicting results in NIPT or chorionic villous biopsy, and positive results, normal results in amniocentesis. So what could be this? So there could be two different cell lines existing, one good and one evil existing in the same organ, that may be the placenta, giving the right apt name, that agathokakological phenomena. So let us dive deeply into what this confined placental mosaicism is all about. So is it a maternal cause contributing to fetal growth restriction there? Fetal cause? No, but it was the placental cause in all three cases, which was liable for the FGR and early signs of placental insufficiency. So all cases we presume that probably because of confined placental mosaicism. How do we define it? It may be defined as the presence of chromosomal mosaicism confined only to the extraembryonic origin of tissue, not to the fetal part, but the extraembryonic part. The incidence is kind of a tip of iceberg because we do not sample all the placenta which are having with the pregnancy, all pregnancies with isolated FGR, we are not sampling all the placenta. So in 1 to 2% of viable pregnancies on the samples we are getting from CVS, the incidence is around 1 to 2%. Whereas in the cases of isolated FGR, 9 to 16% of pregnancies are seen with confined placental mosaicism. Now, clinically, it is very important that we know which cases would behave badly and which cases would behave normally. So the effect on the fetal phenotype and the pregnancy development would depend upon three important factors. The first thing, which are the chromosomes involved. Second thing, how is the distribution of cells, abnormal cells among the tissues, whether it is the trophectoderm, whether it is the hypoblast, whether epiblast, and upon the precise staging at which chromosome mutation occurs. For this, we have to go back to little bit on the embryological part. I would not bore you with the embryological part, but will give you the basic insights of it. So when the mutational event occurs at the blastocyst cell line, prior to the differentiation of embryonic and chorionic compartments, the mosaicism would be found in both the placental and fetal tissues. Whereas when the chromosome mutation occurs at a later gestational age, the abnormal cell may be confined either only to the placenta or to the embryo and not necessarily in both. So another determinant is how much of trisomic fraction is there inside the tissue. So if it is high trisomic fraction, it will be associated with miscarriages, fetal growth restriction, intrauterine demises, and if it is low, then the outcome can be favorable. Now again, we'll take you through two different cell stages. The upper one is showing the 5 cell stages. The outer cell line is trophectoderm, which will give rise to cytotrophoblast and syncytial trophoblast, which we are going to examine when we are doing CVS and NIPT. Whereas it is the inner cell mass, which is again dividing into epiblast and hypoblast. The epiblast will give rise to the fetal cell and the hypoblast would give rise to the mesenchymal core. Now, why this is important? Because there are various possibilities which can happen. So we take 3 different scenarios. In first scenario, when the only diploid cells are retrieved in the biopsy. So just what happens in PGTA, pre-implantation genetic diagnosis. So there could be a normal. The yellow is for normal cell line and blue is for abnormal cell line. So there could be a completely normal fetus and the placenta. There could be fetal trisomy and the placenta, means a trophectoderm outer cell line would not exhibit any abnormal cell lines, or there could be confined fetal mosaicism which can happen. So in all three cases, there would be diploid cells would be retrieved and the results would be normal. Second, when the diploid and trisomic both cells we are getting into the biopsy, what three possibilities can happen? Either it can be a generalized mosaic, means the placenta and the fetal tissue both are showing mosaic pattern, different cell lines. It can be a fetal trisomy as well as the mosaic placenta, or confined placental mosaicism, means the fetus would escape the trisomic part, but the different cell lines would be there into the placenta. When all the biopsied cells are trisomic, even in that case, there would be a component of confined placental mosaicism, because of the reason that the embryos have the capability of trisomic rescue. They will eliminate the trisomic component to the outer core and they would exhibit the normal cell line. So this is the component of CPM, confined placental mosaicism type 2 and 3. So when diploid or trisomic or all trisomic cells, these three scenarios can happen when we get into the biopsy. Little difficult to digest, but this is forming the basics of what we are going to learn further. So is there any importance of learning types of CPM, and is there any having clinical implications? Yes, because when we are testing for prenatal test, it is very important that which test would give rise to what kind of results. So type 1 CPM, that means only the cytotrophoblast, it would be confined to only that portion, and it would be diagnosed by NIPT as well as the short-term culture villi. Type 2 CPM would be confined to the villous stroma, or we call it as mesenchymal core, and type 3 CPM would be confined to both the cytotrophoblast as well as the mesenchymal core. So this is the fact that why NIPT can detect this CPM type 1 and 3, because the cytotrophoblastic component can be detected in NIPT. That's why NIPT can detect type 1 and type 3 of confined placental mosaicism. Another implication that type 3 CPM is linked with cases of FGR and maternal complications in more numbers than other types. And that's why knowing types is of importance. Now, this will also give us an insight about why, which test to prefer to diagnose confined placental mosaicism. So there are papers, more number of papers are coming in, and they are saying that NIPT is more sensitive to detect CPM as compared to CVS, because the entire placental trophoblast sheds cell-free fetal DNA into the maternal circulation, which is not so in CVS, because in CVS we target only the few component of the placenta and we are not targeting the whole placenta. We are not sampling the whole placenta. So the whole placenta may not be sampled by CVS. That mosaic part may be completely skipped while we are testing for CVS, and that's why NIPT is showing a high incidence of CPM. It is more sensitive in diagnosing CPM than CVS. So any predilection of confined placental mosaicism with specific chromosomes? Are we getting repeatedly a few chromosomes as positive in NIPT or CVS? So let us learn deeply into that. So there are chromosomes 2, 3, 7, 8, 13, 16, and 22. I'm sure most of us might have got such reports of NIPT, and we must have counseled many number of patients with 16 and 22 especially. And highest numbers of cases are seen with chromosome 16. Now, what is the possible mechanism why this set of chromosomes are highly linked with confined placental mosaicism? The exact mechanism is not known, but it is these chromosomes have the genes which are related or which are important for fetal growth as well as the placental function. So these chromosomes have been demonstrated to be associated with adverse perinatal outcomes. That's why it is very important that we know which type of chromosome is linked. Based upon that, we can start counseling the patient accordingly. Now, let us take the analysis of what complications? So, okay, learning about confined placental mosaicism is okay, but how I'm going to see them clinically? So yes, clinically they can present with maternal and fetal complications. So there is a meta-analysis which I'm quoting. They have said that preterm birth would vary from 10 to 20%. The chances of preeclampsia, HELLP syndrome, or liker abnormalities can exist in 12 to 30% of the cases. There could be growth restriction, which we are really worried about in 70% of the cases. The postnatal death or IUFD can happen in 2 to 4% of the cases. And there can be structural fetal anomalies. These are not so major anomalies, but the minor anomalies like hypospadias, epispadias, they have reported into the literature. So that they can coexist with the confined placental mosaic cases. So this is important that we get such cases. Even if we confirm by amniocentesis fetus is fine, we have to look for all such complications and we have to include this into our counseling parts. Now, especially we give importance to trisomy 16 because it is a frequently occurring trisomy when we discuss about CPM. So 80% of the cases would have FGR. Premature birth can be extreme in 25% of the cases. Again, intrauterine demise and termination would be there in around 8 to 12% of the cases, and the maternal hypertension also can be there in 5 to 8% of the cases. So these are the this is what the literature speak about the different chromosomal pattern and their categorization into risk stratification. Now, any difference in preeclampsia or CPM? Because the clinical picture would be same, there would be FGR, there would be Doppler abnormalities. So yes, because we know that preeclampsia, there would be a chronic villitis, there would be maternal vascular malperfusion and fetal vascular malperfusion pathology. And the reason we know that it is because of the inadequate trophoblastic invasion into the maternal spiral arteries, which is causing maternal endothelial dysfunction, and that is going to give rise to preeclampsia, which is not so in CPM. So how the CPM placenta differs from normal one? So there is a good study done by a group with MRI. They studied the placenta size and function, and what they found out that it was in all the cases the placenta was enlarged and dysfunctional, and the dysfunction was related to chromosomal subtypes of CPM. Like in 2, 3, 7, 13, and 16, the dysfunction was much more higher. Further understanding of placental function in CPM is essential to facilitate the evidence-based parental counseling and rational fetal monitoring in pregnancies complicated by it. So, should we follow all the CPMs very closely? Well, because we have learned that there are perinatal complications, maternal and fetal complications. So we have to apply some strategy. The monitoring strategy, thankfully, is the same, going to remain the same, that we are going to monitor by Barcelona protocols, serial growth scans and Doppler studies as per the staging. But we have to counsel the parents for impending fetal growth restriction, oligoamnios, maternal preeclampsia, premature rupture of membrane, preterm delivery, and sometimes in extreme cases, IUFD also. And we have to advocate the postnatal placental histopathology, which is the cornerstone of diagnosing CPM. So another paper quotes that it not only explains the pathogenesis of FGR, but also ensures the significant information for postnatal follow-up. Thus, it's of importance to examine the placentas from pregnancies with isolated FGR, because by the time we reach, we diagnose FGR, probably there would be a mid-trimester, and at that point, we don't advocate doing chorionic biopsy to confirm whether it is because of the confined placental mosaicism or some other cause. So when we rule out maternal cause, when we rule out fetal cause, then ultimately we took the blame, take the blame on the placenta, but we do not find the exact placental pathology. So it is very important that we find out and we diagnose the cases which are the tip of iceberg right now. Okay, so there is a word about PGTA and CPM. So the American ASRM, American Society of Reproductive Medicine, and the Genetic Counseling Group, they have gathered together and found out the guideline. They have devised the guidelines. What they are saying that on the basis of available data, the fetal aneuploidy related to mosaic PGTA, the result is very, very low. That is around less than 1%. There are three mechanisms. One thing, either it could be low mosaic cell line. Second thing, there is a component of trisomic rescue, that fetus will eliminate the trisomic cells and only the trophectoderm would show the trisomic part. And third thing, there would be a technical error in biopsying the blastocyst. So these all three are related, and that's why they are not advocating that if they are mosaic, you do not transfer. With proper counseling, if low mosaics are there, there are guidelines they have devised that you can transfer the cells, and later on you can confirm with further prenatal tests whether the fetal part is affected or not. So this was in brief about the confined placental mosaicism. So to conclude, when we encounter such cases, first of all, suppose in NIPT or CVS, we have to confirm with the invasive testing at 17-18 weeks by amniocentesis, and we have to stamp that the fetal tissue and fetal cell line is normal or not. And so indirectly, when we are encountering confined placental mosaicism, we have to monitor fetal growth intensively from first trimester onwards, especially when we encounter chromosomes 2, 3, 7, 13, 15, 16, and 22. Structural anomaly of the fetus should be ruled out. And despite prematurity, the good thing is that CPM fetuses would behave normally, means the long-term outcome of such babies would be quite normal if they escape the growth restriction and other complications of pregnancy. And further understanding is required for to understand the placental function in CPM. Just because we can counsel the parents in a better way and we can devise some monitoring protocols differently rather than combining them with the common algorithm of fetal growth restriction. Now, having said that, there are two questions which ran in my mind while I was making this presentation. Probably I would like Sir to intervene and to give us the insight about this. So when we knew that CVS samples can show the mosaic cell pattern, when the combined first screening test is coming positive and there are no ultrasound findings, should we discourage for CVS and should we push them for amniocentesis? Maybe if Sir can guide us for the same.
Hitanshu, thank you for the presentation. I think what I'm going to do is to rope in Sujatha into the conversation because this is very important, looking at placental mosaicism, and now you are questioning the very basis of doing a CVS.
Yes, right? Sir. Yes, sir.
So it's that's you're opening a Pandora's box, which right. Which will change the literal phase of what we do. So right. In my opinion, I don't think that we should, for all screen positive cases, we should postpone it to amnio. Because the very purpose of CVS is to do early diagnosis, isn't it?
Right.
Now, the question is, when you see a mosaic in the CVS, right. then that patient might, if the fetus structurally normal, then we might want to do an amnio later on. This is my right. take. So let's ask Sujatha whether he agrees with it.
Right, sir.
Yes, sir. Yes, sir. I think what you said is right, because the number of patients where we are going to encounter with CPM is going to be much low. Right, and the number of screen positives which require sampling will be much higher. So I think CVS should not be denied to patients when there is a screen positivity, because early results and early decision making always is very helpful. And right. whenever there is a discrepancy, those cases we can set aside and then confirm about the fetal status and right. then counsel accordingly. I think the number of patients are going to be much less.
Right. Yeah. Right. And so there are some number of questions. I think, Sujatha, for many things we need your answers. First is Hitanshu. Yeah. Was aspirin 150 milligram started for risk of PIH in all these cases?
Yes, sir. Yes, sir. All the obstetricians were quite primed of that, and they've started in all the cases, all three cases.
Yes.
Yes, sir.
And Vidya Lakshmi has asked, interval APLA workup and ASA next time is required.
Yes. So first two cases, they had undergone APLA workup, which came out to be normal. The third one is ongoing, so we did not do the APLA workup during pregnancy. But all first two cases, they came in post, means they went to their obstetrician postnatally, and it was advised and it was sent as a normal. It was considered as normal.
Yeah. Then how can we suspect CPM?
That is probably, sir, the retrospective diagnosis when we do the testing and when we encounter the structurally normal fetus and abnormal reports in the invasive testing like NIPT, means the CVS or NIPT, and when we confirm with amniocentesis, I think that would be completing the whole circle, and that's how the CPM would be diagnosed, sir.
Yeah. So can Sujatha highlight if there's a CPM, are there any signs in the fetus we have to look for?
No, so confined placental mosaicism usually is confined to the placenta. So it mainly interferes with the growth restriction because there can be some abnormal placentation because of the trisomic tissue. And so mainly it presents with fetal growth restriction, and they don't present as a structural abnormality unless there is a mosaicism in the fetus as well. So sometimes there can be a mosaic in the fetus and the mosaic in the placenta. So those situations you can see some abnormalities in the baby as well. But in the majority of CPM, you see only placental insufficiency and the babies are usually normal.
Yeah. Okay. So my question is, so supposing NIPT you're having screen positive for Turner syndrome, and we find Turner syndrome on a mosaic Turner on CVS, do we still have to confirm with an amnio?
Yes, sir. Yes. Because Turner syndrome is known to have problems and known to be seen more often in cytotrophoblast than in the fetus. So if the fetus has an increased NT, if there are signs where you suspect Turner, in those situations, I don't think you need to repeat. But in an absolutely normal fetus, you get a mosaic Turner on CVS, it is better to confirm with amnio.
In other words, the NIPT thing but a sort of a placental biopsy rather than so if you see NIPT positive and you again you're doing the CVS, you are literally sampling the same tissue, isn't it?
Yes.
So that's another thing we need to look at. Okay.
Yes.
Now, why CMA for screen positive 21? Why not karyotype? Good question by Abhijit.
Yeah.
Tell me.
Yeah, because
why do you do CMA?
Just because many times low-level mosaics are identified in the CMA also. So we thought if a partial deletion or so, we may not be able to pick up in karyotype. So as a routine, we send CMA in such cases.
So low-level mosaic, if it is very low, it is again very difficult in certain microarray techniques. Not all microarray techniques are very powerful enough to pick up low mosaic states. So either you count more metaphases in the karyotype or you do fish for 100 cells. That's the way we pick up mosaic. They are more robust than doing 315K microarray.
Right.
So what's the final answer for this? Screen positive T21. Should we do karyotype with that?
Yeah, karyotype is better, sir. Karyotype is better.
Normal fetus. Yes.
Karyotype is better. You can do other techniques like rapid aneuploidy Fisher qPCR can also be done.
Because nowadays it's being considered that if you don't do CMA, if you do karyotype, you're a little old-fashioned, and CMA seems to be the most common thing.
Karyotype is a gold standard, sir. In many situations, karyotype alone is enough in many situations.
Yeah.
So recently, sir, just pardon. Recently, we encountered one case which was even NIPT screen positive for trisomy 21. The ultrasound features did not show any aneuploidy markers. The growth was normal. The amniocentesis, the QFPCR was normal for trisomy 21, but FISH and the microarray showed 2% of mosaic of trisomy 21. So
2% of mosaic is very negligible, sir.
right,
We
ma'am.
don't make any decisions. At least
Yeah.
10% of cell line should
It should not even be
Right,
reported.
right.
to
Exactly.
make,
My opinion, that
Just
should
they
not be
should not be
reported.
reported,
discussion.
sir.
Ji.
2% of
Yeah.
mosaic should not be reported, sir.
Right,
Yes.
right. And ma'am,
And
having said that, NIPT is more sensitive for CPM, and CPM can lead to such kind of maternal and fetal means growth restriction. So should we stick to common 5 for NIPT, or there are labs which are offering all chromosomes for in NIPT? So should we change our strategy to look for all the chromosomes?
All the chromosomes, see, the more you do, the more the confusion you will
Right.
end up in.
Right, exactly, ma'am.
So NIPT is specifically meant for these 5 common aneuploidies, and sensitivity specificity is maximum for these 5. And even for among them, the sex chromosomes, the sensitivity is a little less, but
Yes, ma'am.
we
Right,
do. But for other chromosomes, the sensitivity is quite less.
right, ma'am.
So I think we have to make a clinical judgment. I think clinical judgment is very, very essential.
Right,
And when
Yeah.
you see that there is a growth restriction, you can definitely do a placenta and an amniocentesis even at
Yeah.
6 weeks to confirm if it's a CPM.
yeah, yeah,
Necessarily you need to do an NIPT to confirm a CPM.
yeah.
The clinical
So,
judgment is always there with us.
yeah.
right.
Uh, so can microarray identify mosaicism or only karyotyping? And I think the question has been answered. Right?
Yes.
Yeah. Is CPM possible for microdeletions and single gene disorders? What do you mean by that? Is CPM? Oh, okay. So when you have microdeletion, can you have a mosaic microdeletion and single gene disorder, which is seen only in the CVS and not in the amnion? That's
No,
what. That's what is the.
it is not only in the CVS and amnio doesn't happen.
It doesn't happen. Yeah. Okay. Now, Dipankar Banerjee has asked uniparental disomy imprinting defects. Query.
Yeah, uniparental
What?
disomy, there is a trisomy rescue, then that leads to uniparental disomy, sir. Because if there is a trisomy, there can be 2 components from one parent and 1 component from one other parent. And if there is a rescue, we do not know which component goes away. And so there can be a resultant 2 chromosomes from the same parent and the other parents being eliminated. So trisomy rescue, we do not know which chromosomes get eliminated. So in those situations, you can get uniparental disomy when there is a trisomy.
So what do we look for in the fetus? So when is uniparental disomy testing indicated?
PD is very difficult to diagnose in the antenatal period. The limitations in testing are innumerable, sir. So I think microarray we can do when there is a fetal growth restriction. We definitely do microarray, which has the strength to detect UPD. So those sort of microarray techniques we can use. CN genome and all can detect UPD very well. So we can use those techniques to detect UPD. Again, UPD we concentrate only on a few chromosomes where UPD is more common. And so that is a big science in itself, and a lot of things have still to be understood about these complex mechanisms. It's not testing for UPD in pregnancy.
Yeah. So second is Dr. Dhaval has asked, does CPM lead to a secondary etiology of preeclampsia? So does late second trimester, third trimester SFLT PLGF ratio as preeclampsia screening test, which is altered same as primary preeclampsia?
So we have to study, sir. I think we need to have studies comparing CPM pregnancies, preeclampsia parameters in CPM fetuses and non-CPM fetuses. I think there is, to my knowledge, there is no reference like that which has compared CPM and non-CPM fetuses with biochemical markers.
But we do agree that CPM can lead to growth restriction, right?
Yes, sir, that is there. But the question was whether it is comparable to a CPM and a non-CPM fetus,
Hmm.
we have to study and then give authentic results.
See, the problem here,
It's the same, probably it's the same, but we
yes.
do. Yeah.
Now, the problem here is when you identify a growth, Hitanshu's first case, there's a growth restriction and a CPM was identified. And we find that either can we create a clear cause-effect relationship is the issue, right? We can, whether CPM was the cause of this, because the etiology, the phenotype of FGR primarily play when say placental dysfunction is there. And so, in my opinion, it's very difficult to establish that it is CPM the cause of the growth restriction. In that particular case, as somebody said, we should do APLA testing and other things to rule out other causes of the growth restriction. So when you have a growth restricted fetus, you have to go and investigate it thoroughly, pull all the stops out, and then only can come to a conclusion.
Yes.
One group has studied placental histopathology, and then they found the pathology in preeclampsia and CPM are different. One slide which I quoted, sir.
Okay.
So that's why biochemical markers also have to be studied separately, and then only we will have that knowledge. We cannot come to a conclusion without testing the two cohorts separately.
Right.
Okay. Then Chellappan has asked, in the early 2000, labs were doing short-term cultures and long-term cultures followed by karyotyping. But nowadays they are doing directly microarray on the DNA. Can this change in trend affect the diagnosis of mosaicism? Very relevant question. Sujatha?
Yeah, the microarray, low resolution microarrays need not pick up my mosaicism. Low level mosaicism can be missed in low resolution microarrays. That is definite.
Okay, so is that a blessing or is it a problem?
See, going through the protocols, I think always helps. I don't think we can give up karyotyping totally yet. So
Yeah.
in most of the situation, doing away with karyotype is fine.
Yeah.
But then I think we have to use our judgment in where to use, where not to use.
Yeah. Now, see, the larger question is, should we even know about the confined placental mosaicism? Is it a knowledge, and definitely having that knowledge, is it going to help us to alter the course of the pregnancy?
So I think in the first trimester, there is no emergency to learn about confined placental mosaicism. As and when you see a growth restriction, then when you want to identify the cause,
Correct.
then investigation becomes important. In the first trimester, identifying CPM, I don't think it becomes an absolute necessity.
Yes. Okay. Then Lakshmi has asked, can amniocentesis miss the same as one FGR and later hypospadias postnatal only picked? Can Vidya, are you asking that can amniocentesis miss mosaicism? Are you asking that?
Yes, sir. Yes, sir. Good morning, sir.
Morning.
Sir, this was a case with early onset FGR, where this is 10 years back. So conventional karyotype was when there was no CMA. And then hypospadias I noted at third trimester, but that I couldn't tell the family, but I put in the internal comments. Postnatally, the baby was diagnosed to have trisomy 16. And now she comes for the second pregnancy, and we did an amniocentesis at 16 weeks. Because there was...
Postnatally, baby had trisomy 16 now.
Trisomy 16, they don't...
Trisomy,
they don't...
Postnatally, the baby had deletion chromosome 16, madam.
Oh, deletion.
Micro deletion chromosome 16.
Okay.
And maybe it was a conventional karyotype. It missed that micro deletion chromosome 16 10 years back. Maybe, I don't know.
Okay.
But the hypospadias was very evident in the third trimester scan.
Yes. So micro deletions can be missed on karyotyping.
Karyotype, yes.
because
So
it
what do
depends
we
on
do, sir? What do we do
depending
when
on
you
the
have an
quality
early
of
onset?
band. No, when you have early onset growth restriction, see, I think where Sujatha comes is that when you have a screen positive and you're investigating, you want to do a karyotype is the first line of investigation. Okay, when you already have a growth restricted fetus, then there are two things. In a growth restricted fetus, are you going to offer a karyotype or are you going to offer a microarray? So this is the discussion that we need to have. Correct. Now the only thing is, as you said, uh, small micro deletions can be missed on the karyotype, which may be picked up on a microarray. So where do we draw the line? Sujatha, you have something for that?
No, there is no harm in doing microarray, sir. There is no harm in doing microarray, but use a powerful technique which detects mosaicism also.
Correct.
So don't do a 315K microarray and look for a low level mosaic.
So the bottom line is this: the 315K microarray is sort of similar to karyotype.
Yeah.
Similar to karyotype. When you do a 750 microarray, then it gives you additional information.
Or CN genome.
Yeah, or CN genome.
Yeah.
CN genome is even better. Yeah.
So regarding that SFLT PLGF question, why are we doing it in the third trimester is mainly to categorize this women for higher risk of preeclampsia complications.
Yes.
So that doesn't take away the responsibility of the test because it is not going to plan anything for the aneuploidy screen. It is for the maternal risk. So it still holds good in the third trimester because that is to plan the place of delivery, the timing of delivery, and how to monitor the mother also. So
Correct.
it can be done. It can be done.
Correct. Can CPM be a cause for recurrent severe early onset FGR?
No, sir. Usually no.
Because this is a one-off event. It happens for that pregnancy. It's not something which is recurrent.
Yes.
That's pretty clear. Poonam has asked, kindly explain the slide on origin of cell lines and various possibilities. So you have to, you get the slide ready. We'll meanwhile go to a couple of questions and come back. Gayatri said, in isolated FGR, placenta when sent for HP should be sent for genetic testing for CPM also. So CPM is not a recurrent phenomenon, so that's already answered. In isolated FGR, when you send a placenta for HP, should we be sent for genetic testing for CPM also?
Yeah, there is no harm in testing, sir. If there is no other etiology, if the fetus is absolutely normal, we can definitely test the placenta to see if there is abnormality.
You definitely need to.
But then it is not going to recur. It's not going to recur again.
Yes.
So, what is the intents of investigations we are going to do for a non-recurrent problem? Is a question. So that's why we do only APLA, because we only investigate for recurrent problems.
Okay. So Chalapan has asked again, once you do amniocentesis and ask for genetic evaluation, how do you ensure it's a CPM or a mosaic fetus? So if amnio also shows the mosaic pattern, then it's true mosaicism, isn't it?
True mosaicism, right.
That's the answer. Now, Dipankar Banerjee again, mesenchymal core cell isolation should be done.
Pardon?
No, mesenchymal core cell isolation should it be done. So will you do the analysis on the mesenchymal core? Is the question.
We don't do.
We don't do that.
Done from the cytotrophoblast or this institution.
Yeah. So what test is advised on postnatal placental sample to check CPM? It's the same thing, no? You answer that question. You can send the tissue for karyotyping.
Yes. But then it depends upon which area of the placenta you are going to biopsy.
That also is true. Yeah.
So there may be mosaic patterns. So all of the placenta may not show abnormal cell line. So that is the important point.
Generally we don't do that.
Yeah, generally we don't do because it's going to be a non-recurrent condition. So there is no need to do that.
Yeah. In all cases of CPM, are double markers abnormal? No, definitely not. Very difficult to suspect CPM antenatally, as we already said.
Right.
Mayank has asked, again, a same question, screen positive NIPT, but not combined screening with normal feet structurally can be deferred for amnio as compared to CVS. Actually, not needed. You don't need to wait for amnio. You can do a CVS as well because CPM is a rare thing. So
Yeah,
you can get a quick
want to
answer.
rule out aneuploidy, which is much more common than CPM, sir.
Yeah.
So I think we need not postpone CVS just for rolling out CPM.
Yeah. So Geetanjali Bela said CVS should not be denied. The incidence is very low. In case of CPM, if we do CVS or NIPT, then only we can diagnose. So we'll do more careful monitoring of the fetus and differentiate from other cause of AGR. Okay. Now, what is the accuracy of extended NIPT? Should we be doing this in all patients? Already answered. We don't prefer to do extended. You can do, but you're only contributing to data collection, not for clinical. So when can we diagnose CPM? What is the first sign in placenta for the CVS suspect? No, there is no placental sign, but you see, for example, if you have a partial molar changes in the placenta, you see that thing. Otherwise, you don't suspect CPM by just looking at the placenta, isn't it?
Right, sir.
Okay. Dipankar Banji, direct culture is not good. You need to do long-term culture for mesenchymal cord cell. Okay. Can microarray detect very low mosaicism? Again, we've answered that question already. Microarray, we go for higher resolution microarray. And the whole thing is what level of mosaicism is clinically significant. That's also important to say. 2% mosaic, 3% mosaic is not thing. I think it's
10%.
more than 10%. Yeah, more than 10% is what is considered as significant. Okay, then Zoom user, I said CVS better avoided for combined tests for high risk trisomy 18, 13, structurally normal fetus at 13 weeks. Preferable to wait to amniocentesis. Yes, it's with 13, 18, certainly we'll do a structural evaluation later on.
Right.
NIPT positive, avoid CVS, await amniocentesis. NIPT for autosomes, preferable to avoid. Ecosprin generally does not have a significant benefit in handling the placental problem related to placental mosaic. It's got a specific proven benefit in subgroup of high risk preeclampsia screen, which has a different fetal pathology. Yes, completely correct. Sumati has asked, should we do invasive in all cases of early onset FGR at anomaly scan?
Ideally.
It's a good question. Ideally, very early onset IUGR. When we say early onset IUGR, it's not IUGR which is getting onset at 27, 28 weeks or so. At 16 weeks, if you have a growth restriction, then certainly we will go and do all investigations. Gitanjali, if we are doing amniocentesis for very early onset IUGR and amnio microarray is normal, so can we miss the diagnosis of CPM in this case as a cough? Yes, of course, we can, but we are not going to go and hunt after it. We are not going to be, what is it that you are going to gain once you have diagnosed IUGR? It's what you're going to do with that fetus going on when they are going to deliver. Those kind of things only is important. That CPM does not become important at the time. So what's the difference between low pass West and on CN sequence HD? Sujatha?
What is it, sir? I don't understand the question at all.
What is the difference between low pass West? Is there something known as low pass whole exome sequencing?
No low pass whole exome sequencing, sir. It is only low pass sequencing, genome sequencing, which is what we call as CN genome.
Yes.
And it is 1 resolution, 1x resolution, 3x resolution, or x resolution. We have different resolution. How many times we do the sequencing? So like that they can remember 1x,
Yeah.
3x or 8x.
Yeah.
So the whole genome is queried rather than keeping probes at different intervals and querying only those areas. The whole genome will be queried.
Yes.
Yeah.
Dr. I think Abhijit, you have answered this question. Should amnio be suggested for early FGR? Very early FGR, yes, we will suggest. Dr. Susila, especially when you have FGR and Dopplers are normal.
Yes.
So that's a clear indication that we have to investigate further. And Dr. Susila has said, nice discussion. Thank you all. The title itself is so new. We have to Google the meaning of the Greek word. Well done, Dr. Hitanshu. Yes, the moment I started, and it took some time for me to pronounce that word.
Yeah.
I practiced it several times because morning I have to introduce that. Hitanshu, you put us in a spot.
Right, sir.
Pooja Pable said, fish or QPCR, which shall we go? Fish or QPCR, both are okay, but
Okay.
increasingly QPCR is being adopted because fish is a little bit more laborious kind of process.
Yeah.
When you do QPCR, that's a greater advantage that it also gives you maternal cell contamination. Maternal cell contamination comes up in the QPCR. So that's why that's better. Alpana Vadve, very good session. Thank you, Dr. Hitanshu and Dr. Suresh for such excellent lectures. Alpana Vadve is there. Hitanshu, you have really today opened up something. I mean, the discussions were quite extraordinary.
Thank you, sir.
So many doubts. It's not an uncommon thing to see. At the same time, when a patient is in front of you, you are forced to make decisions. I think these kind of discussions helped a lot. So
Thank you,
just
sir.
that, can you show that particular slide? We have
Yeah.
just got 2 more minutes. You can show the slide and explain.
Right, sir. Sir, so there are outer cell line which will give rise to trophectoderm. The trophectoderm will be giving rise to cytotrophoblast and syncytiotrophoblast. So this we would be testing when we are testing for chorionic villous sampling, or when NIPT sampling would be taken from this.
side gate.
Go ahead.
Yeah, and we have the inner cell mass, which is the true fetal cell origin, and it is again divided into 2 parts: hypoblast, which will give rise to extraembryonic mesoderm, and it will give rise to mesenchymal core, and epiblast, which will be the actual fetal cell line. So when we do amniocentesis, we are targeting on this, and when we do CVS, we are targeting on the cytotrophoblast. So that's how the differentiation. So this is 5 cell stage, and this is 13 cell stage. We can see the hypoblast is snugly fitting near juxtaposed to the outer cell line. So even sometimes when there is trisomic rescue, the epiblast can give the trisomic cells extra rise to even hypoblast and push it towards the cytotrophoblast. So that's how the mosaic patterns can vary based upon the true fetal mosaic or true placental mosaic or mixed mosaic patterns. So this was the slide which they were asking, I think.
I think that's a very clear explanation, Hitanshu.
Right, sir.
I think, okay. Final thank you has come from Poonam. It's 9:59 and time to sign off and look forward to one more. Very soon we'll be in 3 weeks time we'll be having the 600th meeting, and we want the 600th meeting to be a very special meeting. I'll reach out to all of you and we will have a great day on the day. Thank you.
Thank you so much for your inputs. Thank you, Sujatha ma'am, for your great inputs, ma'am.